Okay, tonight, without further ado, we have Heart Health with Dr. Michael McGill of the Marshfield Clinic, Lakeland Center. Dr. Michael McGill is currently director of the One Heart Nuclear Cardiology Program, which features the first CZT, which stands for cadmium, zinc, and telluride, nuclear camera at the state of Wisconsin. Prior to that, he was director of nuclear cardiology at Central DuPage Hospital in Winfield, Illinois, before joining the Marshfield Clinic Minocqua Center cardiology department a few years ago. Following receipt of his medical degree from Loyola University of Chicago, Dr. McGill completed his residency and a fellowship in cardiovascular medicine and nuclear cardiology at the University of Wisconsin. Nuclear cardiology uses a very small amount of radioactive tracer injected into a vein, which then permits a gamma camera to take pictures and movies of the heart. Dr. McGill has a special interest in educating patients about preventing heart disease. So somehow he has to find you before you have to go visit him. His goal is to build our resources and diagnostic tools to detect heart disease in its earliest stages. And Dr. McGill and his family had vacationed here for many years, he tells us. He moved here because he felt it was a great place to raise his family. He's committed to supporting resources that contribute to healthy lifestyles. And to illustrate this, he and his family help raise funds for area bike trails. There's nothing better than a bike ride through the beautiful North Woods, Dr. McGill says. So, all right, here's your trivia question. Dr. McGill is a well-established cardiologist now, but once he was a young and eager medical student. On his first day seeing patients as a second-year medical student, he was so nervous and excited that he, this is where you guys come in, couldn't find his car when he finished and reported it stolen. Security people found it right where he had left it. Or B, he was surprised to find a young man in a waiting room when he thought he was supposed to be seeing a pregnant woman. He was in the wrong room. Or C, he left his brand new stethoscope on a counter where a young child found it and he had to go find some candy in order to bribe him to get it back. Which do you think? Did he lose his car? Did he go in the wrong room? A, he lost his car. I think he's found it now. Thanks so much. Here is Dr. McGill. But you know what? I don't usually do this, but I'm going to ask the first question. Is beer good for your heart?
In moderation, beer is good. So we can talk a little bit about that. But,
all right.
No, it's really interesting. The mortality rate with regard to alcohol intake is such that for men, 1 to 2 drinks actually has a lower mortality than 0 drinks at all per day. And for women, it's 1 drink. And then after that, the curve goes up. So in moderation, a little bit of alcohol is good. And if you're going to drink beer, darker beer is better than lighter beer. And if you're going to drink wine, because of the flavonoids, red wine's better than white wine. And the flavonoid, actually, to plug University of Wisconsin, John Foltz, who's a professor at UW, did all the research on flavonoids and platelet aggregation and had extensive amount of research funds from different wine companies and from Welch's. Exactly. So, we're going to talk a little bit about heart physiology and talk a little bit about the diagnostic tools that we use. And I'm not sure if that's going to impress you or not. So I brought a picture from my days of fellowship at the University of Wisconsin. And when I was there, we had a faculty fellow football game. And the first year we did it, the fellows won by a score of 49-0. The faculty did not take the game very seriously. So we did it the second year, and I think we won 56-7. I think they actually did score a touchdown. But this is a picture that someone took during the game with a panoramic picture. This sits on my desk, and I'm going to want it back, but I'm going to pass it around the room because I want to impress Dr. Melms and Tim Melms, who are in the audience, to show how great of a quarterback I was. So this was a play that was set up, and you can see from the picture that the faculty are either on the ground or they're to the left side of the field, and I actually have 1, 2, 3, 4 wide receivers in the end zone. So please take a look at that. I definitely want it back because that sits on my desk. But we're going to talk a little bit about the heart tonight, and the heart is a very amazing organ. And it's essentially a pump, and it pumps blood. And I used to do a lot of things with the Tribune Broadcasting and WGN in Chicago, And we had this program where we used to go out to schools through their news and education program, and we would do like this little show and tell thing. And one of the questions we would always ask the students is, how many times in the course of a day does the heart beat? And so I'm gonna ask the audience here to raise your hand. I won't pick somebody. You know, I'll pick Tim Elms out. How many times in the course of a day does your heart beat, on average? I know our heart. We were watching the Lakeland boys play yesterday, so our hearts were beating a little bit faster than tonight. But so take a guess. 80,000. Pretty close. Pretty close. The average heart beats about 100,000 times in the course of a day, and that's an important number. We're going to come back to that. But the heart essentially is a pump, and it pumps blood. It pumps nutrients to the cells, and the main vessel that comes off the heart is called the aorta, and that's a pipe that's about 3 to 3.5 centimeters. And then that pipe subdivides into smaller pipes. They're about 1 centimeter to 2 centimeters that go to your brain, to your arms, to your legs. And then those pipes get further subdivided to eventually to the point where the red blood cells, which carry the nutrients, oxygen, are essentially in a single file line in a capillary. And so that single file line of red cells is adjacent to the cells in your body, and those cells take nutrients from the plasma that's in the blood, and it takes oxygen from the red cells to provide the metabolic fuel for those cells. Now, most cells in the body are like my teenage son. They just kind of lay on the couch and don't do a whole lot of activity, and they don't use a lot of oxygen from the red cells as they come by. So if you can kind of picture a capillary is like a train, okay, and it has oxygen, and so if a cell needs the oxygen, it takes the oxygen from the train, the oxygen from the red cell, and then dioxide and waste materials. Most are not very metabolically active, and so it takes very few of the oxygen molecules as they come by. So think of, and there's a train of pepperoni pizzas come by, and every third or fourth car grabs a slice of pepperoni pizza. Okay? The heart is a very unique organ because it beats 100,000 times in the course of a day. So it's metabolically active even in the resting state. You know, at night you go to bed and you don't use your big muscles for hours and hours, but your heart still has to pump. So the heart is an organ that utilizes an extensive amount of oxygen in the resting state. So in that analogy with the train cars, that heart is taking oxygen from the red cells as they come by at almost near maximal capacity. And in order for the heart to get more oxygen or more nutrients, the blood flow has to increase. Whereas the other cells of the body, for the most part, if it needs more oxygen, it needs more nutrients, it just takes more. Okay? But since the heart is so metabolically active in the resting state, in order to increase oxygen or increase the nutrients, you have to increase flow. Exercise or do any type of activity, we can increase blood flow to our heart about 2 to 2.5 times over baseline. And if your pipes are normal, it's very easy to increase flow. But the problem is if you have obstruction to blood flow, and that's related to one of the most common diseases known to mankind, which is coronary artery disease. And coronary artery disease is essentially plaque that builds up in the arteries, and if the plaque buildup is extensive enough, you have limitation of blood flow, and then you have a mismatch between supply and demand. And coronary disease is really of epidemic proportion. About 50% of people in the United States and 50% of people in this room are going to have some form of cardiac or vascular disease manifestation at some point in their life. We know that the earliest forms of heart disease start when you're very, very young. We have data from autopsies, we have data from heart transplant patients, and particularly a lot of data from the Vietnam and Korean War looking at young soldiers. And we know that the earliest forms of heart disease starts when you're about 2 years of age. And it's really interesting, and it's really startling when you look at the facts that kids aged 2 to 15, about 8% of them will have the earliest forms of heart disease. So meaning if you looked at their arteries, you can which is the earliest forms of the atherosclerotic plaque process. By the time you get to be between 15 and 20, it's about 33%. And 20 to 25, 20 to 25, it's on. Can you hear me? Ages 20 and 25, it's about 50%. So this plaque process starts when you're very, very young and progresses to the point at some point later in life where you have obstruction of blood flow. Sometimes you can have plaque that's present and it can rupture, and that produces a heart attack where you just have no flow at all. So this plaque process is the same type of process that occurs with the plumbing in your house. You get a little bit of obstruction and it builds up over time, and eventually you get to the point where you turn on the faucet, there's no water pressure. Okay, so that's what we deal with. And in cardiology, there's such a high prevalence of heart disease that the physiologic basis of that process of abnormal blood flow is the genesis of all the testing that we have to be able to detect it. Okay, so in patients who have obstructive plaque, so the plaque builds up over time, you get a situation where you get a mismatch between what the cells need and what can be supplied. So you get a kind of a supply-demand mismatch, and patients will manifest symptoms of heart disease. And depending on where you live, some places in the north we call it angina or angina. In the south, they call it angina. And that's essentially the clinical manifestations of the mismatch of blood flow between supply and demand. And when there is an obstructive lesion, there's a cascade of physiologic events that occur. And it's those physiologic events, if you understand that, you understand how our diagnostic testing is designed. So the first thing that happens if you have an obstructive blood flow and you have a situation where there's a mismatch between supply and demand is that you have obviously abnormal flow, okay? And the manifestation of abnormal flow, the first thing that happens is the pressures inside the heart start to increase. Now, we have a blood pressure. You measure your blood pressure, and it's 120 over 80. Well, the heart has a blood pressure, too. And inside the heart, the upper number is the same number, for the most part, that is measured. So let's say your blood pressure today was checked, and it was 120 over 80. Inside your heart, your blood pressure, the top number, the systolic number is going to be 120, but there's a bottom number. And that bottom number is usually relatively low. It's usually 5, 6, 7, something like that. So inside the heart, it generates, in that scenario, 120 millimeters of mercury pressure, but then the diastolic pressure is very low at 5. If there's abnormal blood flow, what happens is the diastolic pressure starts to increase. And that diastolic pressure will increase to 10, 15, 20. And when that occurs, since everything is in series, if the diastolic pressure is increased in the left ventricle, okay, that increases pressures in the left atrium, and that then in turn increases pressures in the pulmonary veins, which in turn increases pressures in the lungs. And when the pressures in the lungs increase, you get symptoms of shortness of breath. And that's a very common symptom of coronary disease, particularly in women, having increasing shortness of breath, and it's related to abnormal blood flow, increased diastolic pressures inside the heart. So that's the first thing that occurs is the increase in pressures. The second thing that occurs if the abnormal flow continues for an extended period of time where you have this supply-demand mismatch is that the heart muscle itself just doesn't function well. And so you start to get abnormal systolic function or abnormal pumping function of the heart. The third thing that occurs if you were hooked up on an EKG machine or a monitor is that you start to see some EKG changes. And the last thing that occurs is patients will get symptoms. And if anyone's been in a cath lab, as a cardiologist, we spend a lot of time in cath lab training and doing procedures. We know that when you do an angioplasty procedure or stent procedure, what happens is you deliver this mesh titanium device into the artery to open up a blocked artery. But in order to do that, to expand that stent, and the stent is very similar to a ballpoint pen, that little spring at the end. Okay, there's a balloon on the inside that expands that stent, and when you expand the balloon, you transiently close off the blood flow to that particular artery, because that's how you expand the stent. And if you're in the cath lab and you see this happening, the first thing that happens is the pressures in the heart start to go up. The second thing that happens is you start to see, if you were to image the heart, you would see wall motion changes, because that muscle is not getting blood flow, so it's not functioning well. The third thing that happens is you start to see changes of the EKG, which would be consistent with a heart attack. A heart attack is where the artery gets completely closed off, and we see EKG changes that look like a heart attack. And that happens for several seconds, and then the patient will finally start to have symptoms of chest pain. Now, in that scenario, the balloon is let down, the blood flow is restored, and everything goes back to its normal state. But it's those physiologic principles that we use to design diagnostic tests to detect coronary artery disease. So in its most purest form, without any technology at all, it's just talking to a patient. So a patient who tells me that they get chest pain walking to the mailbox, and they stop, the pain goes away, and then when they start walking up a hill again, they start to get chest pain, that's the clinical manifestation of a supply-demand mismatch. So here's a person who has normal flow at baseline, so those cells aren't getting enough blood, but with exercise, now blood flow, the heart becomes now more metabolically active. The heart has to beat harder because you're doing more things, and there's a supply mismatch because of an obstruction. The heart can't meet that increased supply because there's a flow limitation, and the patient gets symptoms of chest pain. So that's a pretty clear diagnosis. That's clean cut. That patient doesn't need any diagnostic testing because we made the clinical diagnosis, and the next step for them is to send them to the cath lab and determine the anatomy of that particular lesion. But most patients don't present with the textbook symptoms. Many patients have what we call atypical symptoms, where maybe they get funny chest pains, maybe shortness of breath, maybe it's fatigue. It's not very clear cut. So in those scenarios, we have to rely on some diagnostic testing to help us make the diagnosis. And the simplest diagnostic test that's used is just regular treadmill testing. So now we're using the EKG portion. And what we're looking for is abnormalities of the EKG, which would be indicative of abnormal blood flow. And it's a very easy test to do. You need a treadmill, you exercise the patient, we monitor the EKG, and essentially we're looking for EKG changes that would be indicative of abnormal blood flow. So it's a very simple test, very cheap test to do. The problem with that test is that it's not very sensitive. So patients who have high-grade blockages, we can miss the diagnosis up to a third of the time because it's just not a very sensitive test. So it's a good screening test, but it's not where we're going to miss patients. In order to improve our sensitivity, we add pictures. So if we take pictures in addition to assessing the clinical status and doing the EKGs, then we're much better at assessing whether or not they have obstructive blood flow. And one common mechanism to do that is to use ultrasound called echocardiography. And in that scenario, what we're doing is we're exercising the patient and we're monitoring the EKG. And what we do is we take pictures of the heart in the resting state, and then we take pictures at peak exercise. So a patient gets pictures, they get on a treadmill, we exercise and we push them as far as they can go. When they're at peak exercise, we get them off the treadmill, and we take a second set of pictures within about 30 to 60 seconds. And what we're looking for now are the wall changes that would be associated with abnormal blood flow. So if we talked about the paradigm of abnormal blood flow is the first thing that occurs, second thing is diastolic pressures increase, third thing is wall motion changes, fourth, EKG changes, and then the clinical symptoms. So now we're much higher up on that paradigm, so we're going to be a little more sensitive. And with that mechanism or that modality, we can detect heart disease in the 80% sensitivity range. So it's still not 100%. It's better than just using the EKG testing because now we're using pictures. Problem is there's some limitations. We only have about 30 seconds to 60 seconds to get those pictures. So sometimes it's, there's a time delay from when the patient gets off the treadmill to when we can get the pictures. We know about 10 to 15% of patients, just based on their body habitus, we can't get good enough pictures to make an accurate diagnosis. But it's a much better test than just using EKG alone. Nuclear perfusion imaging actually assesses the blood flow pattern to the heart. So now we're even at a much more sensitive place to detect coronary artery disease. And we do that by injecting a radio tracer, and we'll talk a little bit more about that. And we use a special camera, and we take pictures before and afterwards to assess blood flow. The tracer that we use is called sestamib, and it's a molecule that is combined with a radioisotope. So it's a radioactive substance. And this radioactive substance is produced from nuclear reactors. There's only 5 nuclear reactors across the world. And for the most part, they use uranium. There's some other products they can use. And they take the uranium and they bombard it with particles, either protons, electrons, or neutrons, and they make new particles. And these new particles are radioactive. And the byproduct that we that's produced from these nuclear reactions is called molybdenum, MO. It's 99 protons. And what happens is this radioactive substance is in a high energy state because we take a substance, usually uranium, and it's bombarded with other particles, and it produces this high energy molecule. Now, any high energy molecule is always going to fall to its baseline state. So energy always, one of the principles of science is energy will always get to its lowest energy state, just like your teenage son. Will always get to the lowest energy state. And the molecule that's produced, called molybdenum, will decay, or there's a radioactive decay, and it produces a substance called technetium-99m, and the M stands for metastable. And essentially what's happening, if you remember your high school chemistry days, where we have neutrons, we have protons, we have electrons. An electron plus a proton equals a neutron. Okay, so this byproduct from this fission reactor has too many neutrons. All right, so that molecule is going to try to get to a lower energy state, and what it does is that neutron then gives off a proton plus an electron and also gives off energy. When that occurs, because now we have a different number of protons, we have a different molecule, because molecules are determined based on the number of protons that are in it. So we have this molecule called technetium-99m, and that's the tracer that's used in combination with another molecule called sestamib. They're linked together, and that's injected into patients. Now, it sounds scary because we're given a radioactive substance, but the substance that we give is in such low quantities that we could give you arsenic in that dose and would have no medicinal effect. So it's a teeny tiny dose of this radiotracer that we're giving, all right? And this radiotracer is injected into the vein, and it gets to the heart within about 2 or 3 heartbeats. So it gets there pretty quick. And when it gets to the heart, it gets distributed throughout the body, and it goes to all tissues of the body that are living, and it's uptaked into the cells. So if you have a live cell, it's going to uptake this tracer. Only about 1.5% of the total tracer that's given actually gets to the heart, and that's what we're concerned with. Okay, so the tracer gets to the heart, and the tracer, the beauty of this test is that the tracer uptake into the heart is proportional to the blood flow. All right, so this tracer gets in the heart, proportional to the blood flow, and it goes into live active cells. Now, the tracer is radioactive. It's metastable. It has a high energy nucleus. And what happens, just like in the fission reaction, that high energy nucleus is going to go to a lower energy state. And when that occurs, it gives off a gamma ray. So a gamma ray is just a form of energy. And that gamma ray is detected by a special camera that allows us to then make a picture of the blood flow. And it's really interesting. So the traditional camera that's been around forever is essentially a camera that has a crystal in it, and the crystal is composed of sodium iodine. So it's just a big salt crystal. It's a huge salt crystal, and that salt crystal has thallium, which is another molecule that's put in. So when you make the recipe, you put a lot of sodium, you put a lot of iodine, and you put a little bit of the thallium in there. And when you do this, what happens is you produce this crystal that has that has electron holes in it. So there's a lot of energy gaps where electrons can go. And what happens is that when we inject that tracer in the patient and they have a gamma ray in one of the cells in the heart, and that gamma ray is emitted, it interacts with this crystal. And because this crystal has all these energy states for electrons to go, what happens is that gamma ray leaves the patient's body, it interacts with the crystal, and it knocks an electron from a low energy state to a high energy state in that crystal, okay? And then that electron that's in the higher energy state will then go back to a lower energy state, and it will release energy in the form of a photon, which is light. And that light then is emitted, and it's detected by a photocathode tube, and that photocathode tube then converts that photon back into an electron. That electron is multiplied, okay? So we have a multiplication, and then we have a count, a tick. And there's millions and millions of these interactions that are occurring, and we count up the frequency in an X, Y, Z plane, okay, of where these interactions occur. And then we use Fourier mathematics, which is a very kind of complicated form of calculus, and we take the frequency distribution of the count detections and we convert it into a picture. So when we look at the picture, what we're seeing is the more dense the picture is, means that the more counts of electrons, which means more gamma rays, which means more blood flow. So in the end, when we look at the picture is proportional to the amount of electrons that are generated, which is proportional to the amount of photons that are generated, which is proportional to the interaction in the crystal, which is proportional to the gamma ray that's generated, which is proportional to blood flow. So there's all these steps, but it's amazing that it works. And so we get these pictures, and the pictures essentially, it's just like Sesame Street. We kind of match them up. We do a set of pictures with exercise, set of pictures at rest, and we match it up, and the pictures will tell us if there's abnormal blood flow. Now we're fortunate in that we have this new camera called the CZT camera, and it's a different crystal. And the technology's been around for a very long time to produce this more sensitive crystal. The problem is that the crystal's been very difficult to make commercially. Okay, so when you have these gamma cameras, all right, if you've ever seen these cameras, if you've ever had the test, the cameras, it's a big camera, and the crystals inside them are huge. Okay, it's very easy to make a sodium iodine crystal, but it's very hard to make a CZT crystal that's that big. The technology to do that's been around for a long time, but in order to make a crystal that big, it would cost millions and millions of dollars, which makes it very impractical to have a camera in Minocqua, Wisconsin, because it just would be cost inefficient. There's been a group in Israel that figured out how to make this crystal cost effective, and as a result, the manufacturers were able to make these cameras. And the difference between the new cameras and the older cameras is that the new cameras, what happens is that gamma ray that leaves the patient now interacts with this CZT crystal, and you have an electron interaction, and that electron interaction is detected. So now we don't have all these intermediate steps where you have electron to photon to electron. Now we just have that electron being counted, and because of that, we've eliminated all those additional steps, that allows us, number one, to get much better pictures, and number two, we can use even lower doses of radiation. So with the new cameras, not only do we get better pictures, we get better count statistics, meaning that we can get pictures in a much faster time period, and it allows us to use lower radiation exposure to patients. And it really helps in the aid and detection of coronary artery disease. So to kind of give you an example, the traditional cameras, it would take about 18 minutes in the resting state to get pictures, and then after we exercise a patient, about 15 minutes after stress. So you're about 33 minutes on a camera total. With the newer imaging crystal, we can image in about 2 to 4 minutes with each set of images, and we use about 75% lower radiation exposure to the patient. And on top of that, we get much better pictures. So we're very fortunate here, and this is not a plug of what we're doing, but we're very fortunate to have the latest technology right here in Minocqua. We were the first camera to be put in the state of Wisconsin. The second camera will go in at the University of Wisconsin, where I trained, in about a month or so, and then there's going to be a third camera in the state in Milwaukee. And this is really becoming the state-of-the-art technology, and it's really nice, again, that we have this in our backyard. But I kind of use this as an example to kind of show all the science behind, I mean, people undergo a stress test and they get pictures on a camera, and it's a routine type of thing, but there's a lot of science that go behind that, and it's really one of our key tools to help diagnose coronary artery disease, which again is of an epidemic proportion. And it's very frightening when you realize that a third of teenagers have the earliest form of plaque, and part of that is based on the fact that our culture and diets have far surpassed our genetics. Driving here today, I went past McDonald's, and there's a sign that says 99 million served. If you think about how humans evolved over time, we were basically designed to eat grains and berries and maybe eat every couple days. We weren't really designed to have three meals a day with the fat and the meat and the things that we eat. That wasn't our genetic design. And if you were to have a meat diet 200 years ago, you had to put a lot of calories, expend a lot of calories to go out and hunt and get that meat. Whereas now you can just park in a drive-through, and it's pretty easy. You get a 1,000-calorie meal without doing a whole lot of work. And like I said, it's coronary disease is something that we deal with every day. Cardiologists will never be out of business because there's such a high prevalence. But the disease process doesn't start a week before you have the heart attack or a month before you have the bypass surgery. It starts when you're young. And we have, again, extensive data to show that kids 2 years old have the earliest forms of heart disease. So the best treatment for heart disease is to prevent it. And heart disease is preventable. And we see patients every day. And there are things you can't change. The things you can't change are your parents. Right now in 2015, we can't affect genetics. Maybe down the road we're going to be able to turn on or turn off certain genes, but certainly genetics play a role, right? I mean, if your dad is 6'10" and your mom's 6'5", you're probably going to be a good basketball player. If your dad's 5'3" and your mom's 4'9", basketball is probably not going to be your sport. I mean, it's just you can't pick your parents. So if everyone in your family has heart disease, you're probably going to have heart disease because 50% of people we know are going to have heart disease. So genetics you can't affect. Men have a higher risk of heart disease compared to women until menopause, and then women catch up. And as we get older, because again, this process occurs when you're young and progresses throughout life, the older you are, the more plaque buildup you have, the more symptoms you're going to have. So those things are kind of fixed, and you can't do anything about. Things you can prevent, is treat the underlying risk factors, which is if you have high blood pressure, get that under control. We know if you have diabetes, get that under control. Exercise, prudent diet, 1, maybe 2 drinks a day helps. Not smoking, those kind of things. So the things that you can control, definitely will help with regard to prevention, some things you can't control. And, I'll never forget a pharmacist I saw when I was in training in Wisconsin, and he was a guy that was on a Dean Ornish diet. He was in his 50s, and he came in, he had a heart attack, and he had significant heart disease and had to undergo bypass surgery. And everybody in his family died of heart disease in their 30s and 40s, just had a tremendous history. And he did everything he could to get to where he was and prevent heart disease, but yet he had it. And he was so depressed. And it was interesting when one of the other doctors talked to him and said, well, you got to age 50 and you did relatively well, and had you done everything wrong, you probably would have had the same fate as your family and not survive your 30s and 40s. So, you do the things you can. Sometimes you're dealt with better genetics than others. Sometimes you can do everything wrong and live to 106, and sometimes you do everything right and bad things happen. And but in general, if you can control the things you can control, you're doing the best you can. So, with that, happy to entertain any questions. Did that picture get sent around? Did you see it yet, Tim? Okay, because Tim will be impressed. But. All right. All right. Okay.
Okay, so we're just about to, we're getting our speaker wired up one more time. We're good now? Okay, and Carol, raise your hand, okay, is roaming around, and I think we have our first question.
Can you explain a little more about how the image is created? I understand the gamma rays leaving the patient, but are they coming perpendicular from the patient? Are they going at an angle? I don't understand how the bit for bit,
Yeah. Well, the gamma rays are emitted in a 360-degree array. And so there's a detector. The detector there's two detectors that are set at 120 degrees, and it rotates around the heart. So it captures the array of gamma rays that are leaving the patient, and then it's put in an XYZ array, and then a picture's made. So you would think that you would want a circular camera to detect all the rays, and there's different types of imaging. There's a set of imaging called PET imaging, which is a different type of nuclear imaging, and they use a circular array of detectors. But for this type of imaging, what's been found is that two detectors 120 degrees apart that rotates gets as much information as if you had three detectors or if you had a 360-degree detector.
Is there any way to reverse the plaque buildup?
Yeah, that's a good question. There was a cohort of patients in Italy who have very low good cholesterol, which we know historically is inversely related to heart disease. And these patients lived to be 90 and 100, and they had no coronary disease. And so it was somewhat paradoxical. And what it was discovered was that the HDL, or the good cholesterol that their bodies produce, is like a super cleansing agent, and it removes the plaque. And they've actually been able to use recombinant techniques to develop that, and in trials of patients where they get infusions of this manufactured molecule, will actually show regression of plaque. The problem is that the cost of using that is prohibitive, for widespread use. So, good cholesterol, has been shown, or the HDL has been shown to help remove plaque. But for practical purposes, when patients have plaque, it tends to either stay the same or get worse over time. And the best treatment is actually with statin therapies, the cholesterol medications. And the cholesterol medications, what they do is they lower cholesterol, but there's more to it than just cholesterol. It has to do with reducing the inflammation within the plaque, and by doing that, the biological characteristics of the plaque has changed, and it's been shown to you halt the progression of it, but you don't necessarily regress it. So once once the cat's out of the bag, it's really hard to, you can't, for the most practical purposes, reverse the process, but you can halt the plaque progression, with risk factor modification, and particularly with cholesterol therapy.
Question?
So the 2-year-old, is he developing hereditary, or somebody quickly back?
Well, the question was the 2-year-old with the earliest forms of plaque buildup. Is that eating too many Big Macs at an early age, or is it hereditary? It's a combination of both. It's it's the diets that kids eat. We know there's been changes. We grew up with whole milk, till the age of 20, and my kids, the recommendations were by age 2 to change out the milk to 2%. And part of it is that your body needs fats. The brain needs fat for development, but too much fat is not good. And so part of it is genetics, and part of it is diet.
How much of an effect does exercise have on increasing your HDL?
Minimal. If you have a low HDL, it's very difficult to raise the HDL. And for patients who are at risk, the best thing to do is to the paradigm was to lower the LDL, but it's really to reduce the inflammation, which is with statin therapies. Now, exercise has benefits because the vasculature of the body, there's 3 linings. There's 3 layers to it. The most inner layer, which is the wallpaper layer where plaque develops, is called the endothelium. And then there's a layer around that called the medium, which is the muscle, and then there's an outer layer. The endothelium, which is the inner layer, it's like the wallpaper, it's a very metabolically active, they're very metabolically active cells, and with exercise, particularly moderate exercise, there's dilation, and the endothelium gets stimulated, and as a result, it releases substances into the blood that are protective for the heart. And so it always comes back to moderate degrees of exercise have been shown to be beneficial because of the release of these factors from the endothelium.
Question in the future. This sounds so impressive, this diagnostic heart disease. Will the future plans here in the Monaco area enable actually heart surgeries like stents and so on? Anything in the plans?
For that, probably not. Just from the logistical standpoint, there's a lot of factors that go into it, but probably not in the near future.
We have an online question, and it is, why does exercise reduce plaque?
Well, it doesn't necessarily reduce plaque. It helps stabilize the plaque. And like we talked about before, when you exercise, you increase blood flow to the endothelium. The endothelium dilates, and it's a metabolically active cell that releases factors into the blood, and those factors that get released into the blood are protective for the heart. So we know that moderate levels of exercise, help promote heart health, helps improve blood pressure, helps improve heart function.
Is the unit here being used for straight diagnostic purposes, or is it helping heart patients that have already had problems?
Can you repeat? I kind of
The unit here, is it being used for straight diagnostic purposes, or is it also used for past heart patients that have had, say, bypass or stents put in?
Right. Yeah. No. It's used to diagnose blood flow. So, whether you have your native vessels or bypasses or stents or anything like that, it's still helpful as far as determining whether or not there's any changes in the blood flow pattern. So yeah, we use it quite a bit for those types of patients.
Getting back to the exercise, would you prefer the anaerobic or the aerobic exercise, or both?
But it's the aerobic exercise. So what I tell patients is that you want to do something, at least 3 to 4 times a week where you're breaking a sweat. And if you're doing that level of exercise, then you're going to get the benefit. So it's the aerobic exercise is beneficial for the vascular system.
So if you have a really high cholesterol number, but your good cholesterol is really high, part of that. Is that protect you in any way?
Well, it's just everybody's different. And the bottom line is that we're kind of getting away from this cholesterol paradigm in numbers. And if you have risk factors for heart disease, the best therapy is with medications called statins. And everything else has really fallen by the wayside. So any other medication or therapies that lower cholesterol, your numbers look better, you feel good, but it doesn't do anything for you. Okay? And it has to do with changing the biological characteristics of the plaque. And what statins do is they lower your cholesterol, but it doesn't really matter what your cholesterol numbers are. It reduces the inflammation within the plaque. Now let me give you an example. This data's been out for 10 years. When patients come in the hospital, regardless of their cholesterol, if they have a heart attack, their mortality is less if we put them on 80 milligrams of Lipitor in the first 30 days. All right? Does it have anything to do with lowering the cholesterol? No. It's changing the biological characteristics of the plaque. And that's why when you watch TV and they show commercials for Quaker Oats, where it says if you eat Quaker Oats 5 times a day, it lowers your cholesterol 6%. But then there's always a little disclaimer, so it has not shown to reduce the risk of heart disease. Why? Because it doesn't change the biological characteristics of the plaque. So this whole paradigm of what your cholesterol numbers are is really independent as far as what's going on with the plaque. Most patients who have heart attacks have normal cholesterol numbers. Does it make sense?
One other question.
Go ahead.
Do those statins that you're saying that people would be put on, do they have any adverse effects?
Anything has. Drinking a beer tonight has adverse effects. So, there's pluses and minuses to everything, and it just depends on your risk. In general, the benefits outweigh the risk. There's certain patients will have adverse events with muscle problems, which is the biggest, or liver problems. But for the most part, the benefits will outweigh the risk. And and I have patients, and it depends on the argument they have. I have patients who have heart disease. They don't want to be on a statin. And we know that the data, the problem is we don't know the data for you individually. We know the data for 1,000 people exactly like you. So we know that if we put a large number of, if we had 2 groups of patients, one we do a therapy on, one we don't, we know that the outcomes are just tremendously different between the 2 groups. You as an individual, you're an individual, you're not part of that group. But in general, there's definitely benefit. And for patients, it really comes down to what is the argument you want to have. So I have patients who have established heart disease. They do not want to take a statin, and that's fine. And I tell them, I said, do you want to be 85 and complain that you took this drug for all these years and it didn't do anything for you? Or do you want to have a heart attack saying to you, if I would have taken a statin, I would have prevented this? And so it's just based on odds. 50% of people are going to die of heart disease. And if you have a therapy that can benefit you, it makes sense to take that therapy. So I don't have any stock in the. Well, maybe I do have stock. Maybe I do have stock with my mutual funds and some of the drug companies. But it's changing the biological characteristics of the plaque, and the most powerful thing we have is the statin drugs. And anything else that lowers cholesterol has found to be ineffective. The fish oils fallen by the wayside. Some of these other agents fallen by the wayside. It always comes back to the statins, and it just has to do with the anti-inflammatory effects. So heart disease has really changed. It's an inflammatory process more than anything else.
A comment on statins, on the negative effects. I developed severe muscle pain from statins. And after discontinuing the statins, the muscle pain gradually diminished over about a year's time. A friend of mine also developed diabetes as a result of taking statins. So there are some negative effects affecting
right.
certain people.
There's pluses and minuses to everything. It just depends on the risk-benefit ratio. It's like wearing a seatbelt. There are some people who survived this car crash because they didn't wear a seatbelt. But most people that are in a car crash, the seatbelt's going to be protective. So everybody's going to not. It's not an absolute science, and that's the problem. Is that when you do an experiment with a test tube, 100 times out of 100, it turns out the same way. With people, genetics, different physiologic parameters, everybody's different.
How routinely does your technology new camera work?
I'm sorry?
How routinely is it used?
Every day.
So if a person comes in with what they think is possible heart defect, that's the first thing you do?
It just depends. It depends on the on the question at hand. But for patients who we want to detect,
So does it rule out echocardiograms, things like that?
no, they each. Yeah, you just ask how often we use it and does it replace other technologies. Every technology has, its potential limitations, and so we typically don't use just one technology. We use multiple technologies to get at a particular question. So it just depends on the particular instance of the patient, what the question at hand is, that we determine what is the best technology. So it's not a one-size-fits-all. And that's why we have all these other modalities that we have available as well.
A friend of mine fasts twice a week, and you said that genetically we humans developed so that we wouldn't eat every day. How much better is her heart because of that, and do you recommend that we should start doing what she does, fasting?
Well, we there's the Okinawa diet, in Japan, where patients eat 8 times a day, very small portions. So I think our notion of what we do compared to what our bodies are designed to do, there's probably a mismatch there. It just comes down to being prudent, moderation, limiting fat calories, just trying to eat a well-balanced diet. I mean, that's really what it comes down to. So, if you fast, essentially, I mean, there's problems associated with that too, because then your body goes into a starvation mode, and you start to absorb and you metabolize your calories differently. But it's just it really comes down to just eating a prudent diet.
If plaque can develop when you're very young, you say as young as 2, and yet you probably won't have symptoms of heart disease until you're much older, how can you tell if you have plaque? Do you just, when you go to your doctor, you talk about various risk factors and things, and their doctor might say, well, because you have this risk factor, we should do a test? Or how do you know if you have plaque?
Yeah, it's hard. I mean, the problem is we have technologies to determine if someone has plaque, but it's just not practical to use for various reasons. So you can do MRI studies on patients. You can do CT studies with contrast to determine if there's plaque that's present, but it's just not cost effective for screening of the population, and it's not going to be paid for by insurance companies or anything like that. So, in a younger person, you're not going to put those patients through those things. So it just comes down to trying to modify as many risk factors as you can and be prudent. And the problem is, all of us when we're 25 years old, that's not on the horizon. We're not worried about retirement plans or IRAs or heart disease or anything like that. So it's all those things that you do when you're younger that kind of catch up to you when you're older. So the key is to try to prevent it early, and start exercise throughout your life, eat a prudent diet, and if there's heart disease in your family, be a little more cognizant of it. My best friend from college has a very strong family history of heart problems, and he had very high cholesterol. And his doctor didn't want to put him on cholesterol medications until he was 40, which used to drive me crazy. Like, what is magical about 40? So we're finding out now that kids, if they have strong family history of heart disease and they have genetic abnormalities where they have very abnormal cholesterols, now they're getting treated as opposed to not getting treated. So we have a little bit better recognition as far as trying to modify some of those risk factors at an earlier age.
When you assess patients for heart health, do you ever look at their oral health as well with the connections between periodontal disease and heart health?
Yeah, so the question is there a connection? And there's been studies that have shown that periodontal disease or dental disease is associated with heart disease, and part of that is that if you have periodontal disease, you have a chronic inflammatory process, and heart disease now is thought to be a chronic. These plaques are inflammatory plaques, and there's association between the two. So yeah, so we if typically in the cardiology clinic, we're not necessarily addressing their dental hygiene, but it's important that people see their dentists and get their cleanings and stay up on that.
With all the kids now spending so much time on computers and not going out to play as much as they normally do, is there more prevalence of them having heart disease at an earlier age?
There will be. I mean, if you look at the risk factors for heart disease, obesity, sedentary lifestyle is one of them, and this next generation. I mean, as a society, we have more people that are obese now than ever lived and walked the face of the earth. And so, as our society gets more and more sedentary, as we go away from the 1950s Sunday meals to the processed meals, it's a problem. I mean, you watch the nightly news and you see how many kids are obese. It's a huge problem. So, when they're 20, 25, it's the obesity issues. When they're 30, 35, it's the hypertension, and all those things factor in to fueling heart disease. So it's going to be it's an epidemic, and it's going to get worse.
Is there any relationship between heart attacks and emotional health?
It's body count. No, you don't have to pay for it. I think I get it free. So, go ahead. I'm sorry. No, I missed the question. I was focusing on the beer.
Any relationship between heart attacks and emotional health?
Well, definitely. It's we talk about that supply, that mismatch with exercise, and emotional stress does a couple things. One, it increases blood flow, and it also can promote to plaque rupture. And it's very well known that patients who have chronic coronary disease, sometimes we don't pick it up on just our exercise testing, but if you put the patient under emotional stress and do an emotional stress test, so to speak, you'll see abnormal blood flow. So there's definitely an association between emotional stress and plaque rupture, which is a heart attack, and emotional stress and chest pain complaints because they get the physiologic manifestations of that supply-demand mismatch and get angina. So that's a very good point.
Actually, I have two questions.
Okay.
First of all, you mentioned that heart attacks are inflammatory in nature. Is that related to arthritis at all?
There's
or other inflammatory.
Yeah, there's inflammatory markers of the body are associated with coronary artery disease, but it's a very loose association. So there are different screening tests that look at inflammatory markers, and we know that the higher the markers, the higher the association of coronary disease, but it's not necessarily a one-to-one correspondence. There's not necessarily any specific correlation with arthritis or rheumatoid arthritis, but there is an association with inflammation, but it's not absolute. It's not 100%.
Now, everybody's recommended to have annual, semi-annual, whatever physicals, where you go through a series of tests and different things. Will this procedure or other picture-like procedures be done routinely on people when they get a certain age or certain risk factors?
No. The problem is that the analogy would be that I love to use is with mammography. We know 11% of women will have breast cancer at some point in their life, and they get yearly mammograms. More women are going to die of heart disease than they will from breast cancer. But heart screening, just to do it as a screening if someone has no symptoms, is not covered by insurance. And that's the trap we fall into. So we have to have a reason to order the test. Okay, so you can order the test You can do a mammogram for screening, and that's
something that the medical profession should push, that insurance companies cover this. If more people are dying of heart disease than mammograms
right.
or other tests that they do annually or semi-annually, insurance is paid for.
Right. Yeah, it's.
And if this helps, maybe this doesn't help. I don't know.
No, I mean, it makes sense to me, and it makes sense to the physicians in this room. It's just, there's limited things that we can do. I mean, we do a lot of things in medicine that we do because that's how we do it, and it doesn't necessarily make sense. And the question that you have entertained falls into the politics and social economic, and it's a bigger question than the doctor fighting to try to get this. I mean, there's so many layers to that question. So yeah, does it make sense? Yes. We know that if you have diabetes, we know that if we went to Walmart and grabbed 100 patients who felt completely fine, have no symptoms of heart disease, but they have diabetes, we know that 22% of those patients, if we did stress tests on them, would be abnormal. Okay. And there are some insurance plans that will allow a one-time screening of diabetic patients to do a stress test. Most insurance companies aren't going to do that. And you have to understand that, insurance companies, again, this is a whole different topic, but their goal is to keep as much money as possible, and not to do as, exactly. So it's, we do screening tests for mammography that affect 11% of women. 50% of women are going to be affected by heart disease. Screening tests aren't allowed. Now, if they have symptoms, then we can do the test. But we just can't do it just to do it.
How closely does your triglyceride level enter into this?
Yeah, it's kind of changed. We used to, if you have high triglycerides, typically your good cholesterol, HDL, is low. They're inversely related. And we used to target treating triglycerides, which is very difficult to do with medications like fish oils. And we have, there's been a prescription fish oil on the market for some time. What we recently found out is that it really doesn't work, doesn't benefit. So it's we target those individual numbers and we make them look, quote, normal outside of the statins, which is the Lipitor, those kind of medications, we're not really having an impact on heart disease. So we can make the numbers look better, the doctor feels good, the patient feels good, but the reality of it is we haven't really doesn't really change things. Now, if you have high triglycerides, it does put you at risk for pancreatitis, and we know that by lowering the triglyceride levels that you're going to have lower rates of pancreatitis. But as far as heart disease goes, unless it's super, super high, the latest data shows that there's marginal benefit of putting 2-3 drugs on. If a patient has elevated bad cholesterol, which is the LDL, it's very easy to treat. If a patient has low good cholesterol, they typically have high triglycerides. Typically their LDLs are elevated. Most of those patients, in order to get them to goal, are going to require 2 to 3 medications. And what we're now finding out is that it doesn't really matter. The most important thing is to reduce the inflammation. So, nowadays, we used to target like specific LDL levels for treatment, and now the guidelines say it doesn't really matter. We put you on a high dose statin as possible, and it's the anti-inflammatory effect. So everybody's just focused on the numbers, and it really has nothing to do with the numbers. It has to do with the anti-inflammatory. And the ideal way to treat coronary disease, which we don't do, is we should put patients on a statin, have some sort of mechanism to judge the degree of inflammation within the plaque, and then make our adjustments based on that. But we make our adjustments, in the past, historically, we've made adjustments based on what their cholesterol numbers are. And now we're realizing that it doesn't really matter. It's just get them on the medicine to reduce the inflammation. So the whole numbers game has changed dramatically, particularly in the past year.
Yes, thank you. What is the cost of the tests with these new facilities that exist?
It's just like the cost of an airline ticket. It depends on your insurance, and there's a different cost based on what your insurance rate. if you were, well, the hospital, I mean, the hospital's cost is a fixed cost based on the overhead of the personnel, the tracers, the IVs, those kind of things. The cost to the patient, it's everybody pays a different price based on what your insurance is, and that's again, we don't have any control of that as physicians. That's all negotiated by your insurance companies. So it's just like an airline ticket. It's just like an airline. There's one guy that's paying $1,000. There's one guy that's paying $69. There's a family that's paying $250. Everybody, that's the economics of medicine. We have no control over that.
What are your feelings on baby aspirin, daily 81 milligrams daily aspirin?
Yeah, it's the reason that you don't see the commercials. I mean, there are commercials to reduce or to promote baby aspirin. It is effective in higher risk patients to preventing heart disease. It also prevents colon cancer. The downside of any type of aspirin therapies is the risk of bleeding, and that's why you kind of have to look at the pluses and the minuses. So for a younger patient, it probably doesn't make a whole lot of sense. If you're older and you have heart disease, it's probably one of the most effective therapies that we have. So, Ann Hunt's here, my nurse, and a patient has coronary disease. The two medicines that I want to see them on are cholesterol medication, statins, and aspirin. Those are the two most important medicines. I tell people if you have heart disease, you're on a desert island, those are the two medicines you want to have. So definitely beneficial.
I can't think of the name of the company. There's a company that comes around here once a year where I believe a mobile unit where they will do the scan of your arteries and whatnot and take a picture to see the blood flow. Is that very useful?
Yeah, I mean it's for the cost. I mean it's not high tech equipment that they use. I've seen some of the results of those tests. If you're a patient who has heart disease, you've had bypass surgery, there's no reason to do it because you're just wasting your money because you should be on the right therapy. So if you're someone who has no history of heart disease, no history of vascular disease, and it's a screening test that you're paying for, and they detect some early disease, then it's beneficial because then you can get some secondary treatment.
We haven't talked about arrhythmia, electronics of the heart. When does it get into effect where it really is a concern for you as a person?
I'm not sure what you're asking. So you're talking about arrhythmia, which is an irregular heart rhythm, and that's just a big umbrella diagnosis, and it just depends on what type of rhythm it is and what your heart function is, and there's so many things that you have to know to be able to answer that question for a particular person.
How are we doing, folks? A few more questions? Okay, I'm going to ask one last question. If you don't usually do this as a routine test, but you go to your doctor, is there anything that you can ask your doctor to do for you or to test if you're a reasonably healthy person that would help assess your heart?
Well, I think if you're a healthy person, you want to know your numbers. So you want to know what your BMI is. You want to know what your cholesterol numbers are. You want to know what your blood pressure is. And if there's any abnormalities, to do what you can to treat that. So I think the key is just to know your numbers.
Okay, great. All right, well, thank you very much, Dr. Mike McGill.
All right.